A very good evening to all of you who are gathered here today for our weekly Saturday Vibes lecture. I just feel very happy when Dr. Anjali Capila comes on the forum because I remember when we started these talks, I knew absolutely no one working in the Himalayas. And during the pandemic, engaging with her, she introduced me to so many wonderful scholars who work, and not only scholars, stalwarts in the field who work in Uttarakhand, and her own work that she's done. I got to know her closely with Vijay Lakshmi ji. These two are like our advisors, and in between we have been, in continuous touch. Sometimes, life takes you on a different role, but I value them so much in this whole affair of the Himalayas. Like nothing that we do is incomplete without their contribution in terms of their vision as well. So I truly consider you a part of HICS, ma'am, and
Thank you
really
so
want you
much.
to continue to come and do workshops there. Because now
Hmm.
we have a good space, it's nearer, mobility is
Yeah,
far more easier than going to Kullu.
yeah,
That was one main reason of moving also, so that we are much closer.
yeah.
So about Dr. Anjali, her qualitative research focuses on folk songs as vehicles of social change and women's empowerment. The work provides unique insights into traditional health practices that inform today's generations of women. And if you remember, just a few weeks ago, we had a talk on Tibetan practices, Tibetan medicine, and how Dr. Dolma also wanted to focus on women. And it becomes women because women are eternally shy creatures. They don't talk about their health problems openly, and it's very important to address this in rural Himalayas, that how to approach the subject and how they navigate their life through this. Dr. Kapila has served as an associate professor of communication systems and media planning and advocacy at Lady Irwin College, University of Delhi, and as program officer for adolescents in the International Planned Parenthood Federation South Asia Regional Office. She remains deeply involved with rural and semi-urban communities of the Kumaoni women. She has authored two books, Images of Women in Folk Songs of Garhwal, Himalayas, and also Traditional Health Practices of Kumaoni Women, Continuity and Change, which was published in 2004. Her anthropological studies have also revolved around the songs which have captured the essence of our incredible, intangible cultural heritage. And of course, like I said, she is a pillar of strength for HICS as our advisor. Join us for this wonderful talk with her. And also, like whenever we engage with scholars of that caliber, we get insight into how our research and the way we look at things should be focused. So it's very important to hear them out, understand their methodologies, and understand that these little things that we kind of oblivious of in the background, the whole methodology that scholars use, are very, very important into making change and connecting our traditions with a past, with a present, which is really fruitful for us. So, ma'am, over to you with your
Hmm.
talk. And
Thank you, Shonali.
yeah, so let me know when you would like me to share the screen.
Okay. So just to, those of you who've listened to my other talks on the X platform, you know that I speak about songs and the songs of the river Ganga. I've had 2 or 3 talks already. But those of you who don't know how my interest in the Uttarakhand region began, I would just like to say that I had gone on a trek with 3 other women to the mountains, and I heard 2 women sing from one hill to the other, and there one was singing the song and the other one was answering back. And when they came down to the roadhead, I asked one of the women, your song was so beautiful, what were you singing about? And she turned around, she was tired, she had a heavy head load on her head, and she said, what do you have to do with my song? And these words, like, these are transformative words. There are many moments in one's life when your whole life gets altered. And I do sincerely believe, with all humility, that this woman who said this to me, what do you have to do with my song, changed my life completely. And I began to want to understand her life through her song. And that was the journey that began it's like looking into a mirror. So when you look into a mirror, you get a reflection. So looking deep into a culture through the mirror of her song, the song became her entry point. And I started collecting songs for my first book, which was also my PhD. And I recorded 150 songs, transcribed them from Garhwali to Hindi, then from Hindi to English as they appear in the text. And these songs are about different aspects of women's lives in the Uttarakhand region. And they are very, very rich culturally, as well as they give deep insights and meaning into her life as it articulates through her socio-cultural history and in a geographical terrain, which is very different from the terrain that we live in. Now, how valuable is a song becomes evident through understanding the content of the song. While when I finished this work, I just felt that while I had looked at women's songs, I had not really understood at all about her health practices and her wisdom related to her own body. So in 2002, I went to the area called Kumaoni, the Ramgarh block, Nainital block. And there is an NGO located called Central Himalayan Rural Action Group. Now, this NGO works in the communities around the Mukteshwar Sitla area, and they work on health practices in about 15 villages. So the leader of this group, Kanai Lal, he said to me, Anjali, that maternal mortality is very high in this area and women died due to multiple pregnancies. So would you like to set up a adolescent training center for rural girls so that we can address this issue of high maternal mortality, because the young people are the future mothers and future women of this region. So when we did this, I told him that I would like to first study on the ground what is women's wisdom related to their own health practices, and based on their practices will I set up a Kishori Shikshan Kendra. Because it's very easy to just set up an institution which is based on your ideas of it or your perception of it. But it is more difficult to understand things on the ground and then set up an institution. So I did that. And this presentation, which I'm going to share with you today, is about the traditional health practices of Kumaoni women, continuity and change. I use the word continuity. What are the practices that continue? What are the practices that need to change, that are not based on a scientific temper and denigrate the life of a woman in her own environment? So it is a kind of a holistic understanding. This talk I gave at the Harvard School of Public Health, since it is based on gender health concentration. So I hope you will travel with me on this journey today and understand women's health practices.
Of course, we are ready. Let me know, ma'am, when you want me to click on share screen.
Yeah, can you do that now?
Yes. Yes, ma'am.
Okay. So as you can see from the screen, there's a little sketch of a Kumaoni village. Since I sketch all my work, most of my books have my own sketches. Now, why are illustrations so important as a methodology of understanding what is on the ground? Is because it is a visualization and a visual representation of what you see. And it connects very deeply to what you are looking at. So that is my way of expressing. So the title of this talk is Traditional Health Practices of Kumaoni Women, a Qualitative Perspective. Now, why do I call it a qualitative perspective? So in this research, you will see a mix of both quantitative and qualitative. While the quantitative data gives you indicators about what is actually happening on the ground, the qualitative perspectives adds a body of knowledge to the quantitative data. So this matrix of understanding both together becomes very significant for any body of work. Next, Shonali. So the outline of the talk is like this. I will talk about the backdrop. Now, why is the context in which the research is conducted important? The context for any research is important. It's not only important for this research, for anything that you look at, the context in which it occurs is very, very significant, because the context is what adds body to the domain or the discourse of the knowledge that is going to be shared with you. Now, every research has a conceptual framework. My framework is looking at culture, health, and development. So these are the three great indicators. The methodology, then I talk about the methodology and the process of fieldwork. Then we'll just quickly go through the key findings, that what did I find, what are the highlights, and a resulting action plan and some concluding thoughts. So this is just the outline of the talk that I'm walking you through. Next.
Yeah.
So let's look at the background. So this study is set against the high central Himalayas of the Kumaoni region. Next slide, Shanali. So I want you to just understand here, you can see the layers and layers of mountains that rise into the majestic Himalayas. So Chirag, the Central Himalayan Rural Action Group, is located here. And we are studying the villages that are located in this geographical terrain. Because of the high mountainous region and the livelihood systems have small land holdings for agriculture, the produce from the land is not high enough to sustain the agricultural requirements of the family. So the family has to pitch in and buy food from outside. And so therefore food security becomes a very important aspect of the livelihood systems of the community. And while women have to walk longer distances because there is deforestation, all that affects their health and their well-being. So that is why studying the livelihood systems, now you're getting slowly the context, studying the geographical terrain, studying the livelihood systems gives you a deeper understanding of the culture and the region before you begin to study the health practices. Because if you know, now in Delhi, the land is plain. If a woman has to navigate the land to go and get water from a hand pump, it's different from having to walk 10 to 12 kilometers on a slope. So all that affects her body and it leads to pelvic inflammatory diseases. So that is why I studied the context and the livelihood systems. Next. Now here are the daily burdens. You can see that women walk long distances to get fuel, wood and fodder. And all this has a deep impact on what? On her pelvis. Because what she does is sometimes, in order to prevent going twice to get fuel, wood and fodder and water for the household needs, she carries it all at one time. And sometimes they carry 40 kilos of head load. Now, where is it going to impact her? She suffers a lot from pelvic inflammatory diseases. And this adds to her daily burdens. Next. Now, despite this, I found that, women have a joyfulness about them. What their daily lives do not bring pain and suffering to them. What is it that they believe in a larger context of the beauty of the Himalayas, of the beauty of nature, that makes them smile and become joyful in this area? So all these issues started, impinging on my mind, and I wanted to understand a deeper meaning of who she is. How does she tick? How is she culturally rooted? How is she centered? What is her self-esteem? How does she see herself? What makes a difference? And I think perhaps looking at self-esteem and health itself was a great new indicator. Next. So now you see my conceptual framework. So I'll actually look at culture, health, and development in this context. In my earlier work, I've looked at culture, ecology, and development. In the Songs of the River, I've looked at the cultural context, the ecology of the river, and the sustainable development agenda, and how people's lives are impacted by the creation of the development agenda, in this case, the dam. So these three conceptual frameworks, for every research, you can make your small little boxes and see how they interact with each other. Culture is related to health, and health is related to culture. Culture is related to development, and development is related to culture. Health is related to development, and development is related to health. So all these interlinkages as a conceptual framework are very, very important. Next. Now, what did I do? let's talk about what did I do and how did I do it. So the step one was the quantitative data. For the quantitative data, I developed a questionnaire with about 60 women. And this questionnaire focused on women's perception of health, menstruation and pregnancy, traditional practices related to childbirth, postnatal practices, family planning, contraception devices, and women and health issues. So the quantitative data, I developed a questionnaire for about 60 women. These women came from 6 villages, 10 women from each village. So in order to, in order to get a wide spread data, I took 3 villages which were assisted by Chirag, where they had health inputs. And I took 3 villages which had no infrastructure for health to see what was the status of women in that, so that you could make a kind of a comparative, how health intervention by an NGO had made any difference, if at all. Next. So for the qualitative aspect, I spoke to over 200 women. I spoke to community health workers. I spoke to midwives and dais. I spoke to young people in the community about their needs and their concerns. I spoke to the Chirag health staff. And I also spoke with health service providers from the government infrastructure. Now, some of you may know the government infrastructure has the National Rural Health Mission, and there is a primary health center and a sub-center, and there is an ANM and an ASHA worker. So all these staff also I interviewed and spoke to, because I wanted to understand their perspectives on where they think are the gaps and whether NGOs are taking over the government agenda rather than making government responsible for their delivery of health systems. So this richness, this provided the richness to the data, the quantitative data, because sometimes just an indicator like 30% women do this, 20% women do this, does not give you any insight unless you supplement it with the qualitative perspectives. Next. Now here you see some illustrations which are little squiggles, and these are very important in our discussion, because here I use different methods for the process of field work. My first approach was that I visited with the health team of Chirag, the community health workers' home. There I would interact with the women in the home. I would visit individual homes with the health extension worker. And I would also visit the local balwadi, because the mothers used to come at 12 o'clock to pick up their children from the balwadi. Now just see how you have to think of a longitudinal way of getting your data, and where you can't tell women that, please come to my room and I will interview you and I will talk to you. You have to go to their own spaces because you respect them. The second approach that I used was that immunization camps were held in clinics in this area. So I would go to the immunization camps because the mothers would be bringing their children. And at these camps, I would communicate with the community CHWs, community health workers, and the DIs. And I would also attend a monthly meeting of community health workers and DIs, which was held at Chirag. Now, this monthly meeting really was a very, very rich source, because, the community health workers would talk about their problems. Didi, we go to the different villages, we go to the homes, but women are not available. They already leave to get fuel and fodder, and it's very difficult to communicate with them. So what should we do? What are the strategies that we should, evolve to reach women at their own spaces? So this kind of sharing and interaction became very, very valuable to understand what is going on the ground. My third approach was to go to self-help group meetings. Now, you know what self-help groups are? Self-help groups have been formed in the community for financial outlays, where women given a certain portion of money, and when this money is collected, any woman can have access to it by asking for it to buy a buffalo, or if she needs some kind of health care, or she needs to be institutionalized or go to a hospital, she can ask for this money. So I would attend these meetings. Then I would interact with the women that are present at these. I also visited the primary health center, which is located in the block, to understand whether women access the primary health center or not, or they don't have the time, or they don't have the inclination, because access to healthcare is also very important. And then I also went to meet the chief medical officer in Nainital. Now you'll say that in understanding traditional health practices, what has the chief medical officer got to do with this whole? But it's very important to meet him, also to share with him that this is what I'm doing on the ground. I'm trying to understand the ground reality so that I can set up a training center for rural adolescent girls, which will focus on their own health needs and also improve their health status, and especially because maternal mortality is so high in this area. Next, Jonali. So let's look at some key findings and highlights. So this slide I named Women's Wisdom. On the left-hand side, you see a Dai, a traditional birth attendant. Her name is Kishni Devi, and she had given birth to about 1,000 children in the community, and not one child had died. And when I used to ask her, Kishni Devi, you are so, तुम्हारे हाथ में इतनी शफा है, भगवान ने तुम्हें इतना कुछ दिया है. So she said, it has nothing to do with me. It is all the grace of God. Because I come from that situation where everything that I do, I offer to the higher. I am only an instrument. And I feel so happy that I've been able to give birth to little children in the community, and not one child has died from my hand. Now, when I was looking at women's wisdom, some of the issues that came up were perceptions of health. Now, WHO has given a perception of health, a definition of health. I wanted to understand the definition from the women themselves. You know, like women would tell me, Didi, jo khush hai, wo swasth hai. If you are happy, you are healthy. Now, not many books will give this definition of health. If you can go about your work, you are healthy. If your children are happy and healthy, you are healthy. If your husband is healthy, you are healthy. If your family is healthy, you are healthy. So they had a very simplistic way of looking at health, but their perception is very valuable, because what they told me, that you cannot separate life and health. Life and health are joined together, and जिंदगी और स्वास्थ्य एक दूसरे के साथ जुड़े हुए हैं. Then I looked at access, whether women go to clinics or not, or they just heal themselves at home. I also looked at women's health-seeking behavior. Do they go and access health? जैसे नहीं दीदी, अगर हमारा पति बीमार है हम उसको ले जाते हैं, अगर बच्चे बीमार हैं हम उनको ले जाते हैं, अगर मैं अस्वस्थ हूँ तो मैं अपने आप को खुद ही ठीक कर लेती हूँ. So the value that she has for her own self and her self-esteem is low, and she does not think that she is significant enough to seek health infrastructure for addressing her health issues. Then I also looked at family planning. Women, the younger generation is using contraception, but they do not use the condom. They just use the IUD, the intrauterine device.
Ma'am, you can take a 1-minute break just so that you feel better. We don't want to stress you out.
Yeah, but actually, Sonali, I'm not well.
Yeah, okay.
I have a very bad cough, which I picked up in Pondicherry when I had gone to Auroville. So,
but we are thoroughly enjoying your talk. It's so wonderful to see the way you have done it.
Yeah, there's a lot of detailing here, and which I would love to share. But okay, I'll stop. If I get a coughing fit again, I'll stop. No,
yeah, continue as long as you are we want you to be comfortable.
Yeah. So then when I looked at mother and child health practices, so I also looked at the food patterns. Now, why is food consumption very important? Because all of us know that food consumption patterns are related to health. In their case, they had some very strange food consumption patterns during the menstrual cycle. They do not have white things, like they do not have milk and yogurt and all. They restrict the use, and they only drink black tea. During the third trimester of the pregnancy, instead of giving the pregnant mother healthy food, they restrict her food intake, because they say that a big baby is difficult to give birth, and then you have to use forceps and go for institutional delivery. So this is very strange that they actually restrict the diet in the third trimester of pregnancy when actually they should be giving her more food. And sometimes this is what weakens women's health, and she is sometimes not healthy enough to fight the infections that go along with childbirth. Now, menstruation was a major issue in this community. I did not find this kind of segregation so much in Garhwal when I was studying the women's uh, songs, but in this area, in the Kumaoni area, during the menstrual cycle, women are segregated. And historically, they were segregated at about 4 or 5 kilometers away from home in the jungle, in caves, and small structures were set up in the forest, and a woman was segregated over there, and one other woman from the house would just come and leave some food outside that shed, and she would never give her white tea. She would just leave some black tea. Now, this kind of segregation is also rampant in many other parts of the world, and also in India also. In fact, I looked at a book called The Red Tent by Anita Damien, which was looking at segregation practices in the Middle East. So India is not the only place where all this happens. But the only thing is, when I interviewed women and talked to them, they said that, this makes us feel very low about ourselves, as though we are some lowly creatures who need to be segregated and denigrated during a natural biological process. And why white is not given to them is because the cow gives milk, and they think that if a menstruating woman drinks milk, then the cow will stop giving milk. Now, what is the correlation between a menstruating woman drinking milk and a cow giving milk? There is no scientific correlation. So some of their practices were really not very, very scientific. They were based on cultural practices, which I feel, maybe it was to give rest to the woman so that she would not, go to the forest or something, but to put her away, far away from the home. And when I interviewed some of the elderly women, they said कि जब औरत को महावारी होती है तो धरती की 7 परत जल जाती हैं. 7 layers of the earth are burnt with her menstrual blood, and she is impure. So that is why she's segregated. And if a menstruating woman comes in front of a man, he'll get boils on his face. Now, all these kind of sharing, while it was very significant for me, I could not derive the meaning of all this from just talking to the women. It was difficult, I have to add, to talk to the men. I could not have a discussion with them regarding these issues. Of course, I would discuss all this with the health clinic doctors in the Chirag staff, and we would have long discussions on how this kind of thinking processes can change. Now, what I want to share here is that the younger women in the household, that is, women who are 22 or 23, who have just been married and all, they were not being segregated into the caves or into the cowshed, but they were just asked to stay in the house in a separate room for about 4 or 5 days, not cook, not touch any achar or any cooking material that was lying in the house. And after 5 days, they could go down to the river or and bathe, and then come and join the family household for doing the different chores. So a lot of change had come, but even those women who were segregated, felt not so good about themselves because they had been to school and college. The age of marriage has now increased. So some of these practices that I'm sharing with you, were from the elderly women who had got married in 12 and 13. And some of them had their first menstrual cycle, can you imagine, in their in-laws' home. So that makes a lot of difference, because what would happen is then she would be segregated by her mother-in-law. In her mother's home, it was a different thing. Now, very interesting is that if you are a virgin, so-called virgin, Kanya, and you are not married even till the age of 30, you are not segregated even during your menstrual cycle in your parents' home. So the marriage of the woman has something to do with her becoming impure, and segregation happens. So in many households, I found, girls who were about 24, 25, and they were, of course, they had their menstrual cycles, and they were not segregated. They were participating in all household chores. They were doing everything within the house and cooking and everything, because the mother would say that she is not impure yet, she is not married. Ye kanya hai, aur kanya ko hum poochte hain. So their practices are really very, very not easy to understand. You have to read my book to understand the deeper practices, the deeper innuendos related to these kind of practices and how they affect women's self-esteem. So I'm making a plea for linking health practices with the self-esteem of a woman as an indicator of the health status of women in communities. Not many people have done these kind of correlations, but these correlations are very, very important because, we always go for indicators like what is the level of disease, how many people are having institutional deliveries, how many deliveries are home deliveries. We just go for these kind of figures. We don't want to understand other factors that are existing within a cultural context that may have a bearing on women's lives. Now, the next issue was pregnancy and delivery. As I told you, during the pregnancy in the third trimester, they restricted her diet so that she does not produce a very heavy child. Delivery was held within the precincts of the home. Now, delivery is done by a traditional birth attendant. And what is done is that in the home, a kind of a hook is put in the ceiling and a rope is dropped from there. And a few bricks are put on the ground and the woman sits in a squatting position and the dai assists her from the back. Now, why a squatting position and not a horizontal position as is done for us? Because squatting is related to the gravitational pull. So this is a very, very scientific thing. Even now in the Hmong communities in the US also, who I looked at in terms of health practices, they always use the squatting position. And in many, many natural childbirth centers, they are going back to the squatting position because the horizontal position is against the gravitational pull, which is not very good, not easy for a woman to push. So here they have a scientific practice. Another very interesting thing I noticed about the delivery is that when the baby is born, the placenta, which covers the baby, is not thrown into a dustbin like in institutions and hospitals. We have no value for the placenta. The placenta is taken out by the dai and a few women of the household, and they bury the placenta under a fruit-bearing tree. And they say that just like you continue to bear fruit and give milk, may she remain healthy and continue to bear children and be healthy and joyful and happy. And they sing a song to the tree, and they put some flowers in a copper plate, and they put a vermilion dot on the tree and bury the placenta under a fruit-bearing tree. I found this interconnectedness with nature quite amazing, because see, what does, we all are very urbanized and we have literally made ourselves so far away from nature. Our health practices do not connect us with nature. And this beautiful practice of, worshipping the fruit-bearing tree and burying the placenta under that shows the deep interrelationship of nature and women's lives in the community. Next. So I also tried to look at how work roles affect health. Now, see, these kind of interlinkages are new indicators, but they become very important. If you see that woman carrying, this is a sketch I did of women carrying different, doing different tasks. She's bringing water, one is carrying stones, one is carrying a heavy head load of fodder, the other one is working in the field. Now, health and work roles are also related because of the heavy head load, it affects her pelvic. So when I studied what are the common diseases in women in the community, PID and white discharge, gonorrhea, because they don't have enough water to keep themselves clean. Sometimes they don't bathe and they have repeated white discharge and UTI infections. But pelvic inflammatory disease and retrovert uteruses was the most common. That is why this interlinkage between health and work roles was looked at. Next. Now, in this slide, I'm going to give you 5 new indicators that I looked at. I began to look at the interrelationship between family, society, and health. And I felt that we could not divorce these from each other. Now, a woman's status in the family, if she is the youngest daughter-in-law, she is not able to make decisions about her physical body, that even if she wants to have an institutional delivery, she cannot articulate this in the house and say to her mother-in-law that मैं घर में बच्चा नहीं पैदा करूंगी, मैं hospital जाऊंगी. So her position and status in the family has a deep impact in her health. Now, men's participation, you will wonder why men's participation. This is a whole new discourse. When I was the program officer for adolescents in South Asia, I spearheaded a whole new manual called Men as Partners in Sexual and Reproductive Health as Women, because I found that whenever men are involved in women's pregnancy and accompanying them to the clinic, women have a better status in the family, because the man is able to talk to his mother and say that माँ आज मैं उसके साथ डॉक्टर जाऊंगा, डॉक्टर लेडी को देखने जाऊंगा, इसकी जो डॉक्टर है उसके पास जाऊंगा, इसकी सारी जांच कराऊंगा. So the mothers and the other women in the household, they may ridicule him and say तूने चूड़ियां पहनी हुई हैं, तू क्यों जाएगा, कोई दूसरी औरत नहीं जा सकती उसके साथ, तू क्यों उसके साथ जाएगा. But studies have categorically shown in the different regions in South Asia that where male involvement is high, women's health status and pregnancy is much better. And now self-esteem, I have given you several examples through my whole process of discussion where self-esteem is related to health. You have seen that women's health, self-esteem during segregation, during pregnancy, during menstruation does affect her, and also her health-seeking behavior. Since she does not value her own health, she only values the health of her husband and her children, and her self-esteem is low, which leads to a low health-seeking behavior. So there are studies in psychology on health-seeking behavior which link self-efficacy to self-esteem, which those of you who are interested can look at. Now, decision-making is also related to her health. What is her ability and her power to make decisions, to take decisions? That also gives her an important status in the family and in the society, and it has an effect on her health. The right to information. Does she have the right to information? We are talking about media proliferating and television in every household, but who's watching the television? Janani Suraksha and all these kind of programs, that wonderful mother and childcare programs that come on television, they are not even watched by the women because they are so busy. So does she have a right to information? If she had a right to information, then she would also know about what are the programs, what are the accessibilities for her that exist in the society. And then the last and very important one is the voice in the community. Now, I attended several meetings with women where health service providers were present, but where also the men were present, and the women would not even open their mouths and talk about what were their main issues, which was not very nice, because when they would sit with me, they would talk about so many issues that they had brought up related to their own healthcare. So having a voice in the community, having the right to information, participating in the decision-making process, having high self-esteem, male participation and status in the family, these may not be normal indicators that you may come across in health books, but I added these because of what came out from the ground reality. And I wanted to build up the Kishori Shikshan Kendra based on these indicators so that these issues are addressed in that training center for rural adolescent girls in Kumaoni. Next. Now, the existing health infrastructure is that there is a government infrastructure and there is an NGO infrastructure. In this case, it was Chirag. Now, both these are, operating at different levels. They don't overlap their agenda. And that, I think, needs to be addressed as a very important issue. And I have flagged this to many bodies of healthcare providers, that the NGOs, they try to take over the government agenda, whereas they should make the government responsible, and they should work in tandem with the government. So that if the ASHA worker or the health worker of the government is going to do immunization, the NGO should not be duplicating its, because in many villages I used to say to the ANM, आप कैसे बैठ के स्वेटर बुन रही हो, आज तो तुमने गांव में जाना था, आज तो तुम्हारा इम्यूनाइजेशन का दिन है। दीदी वो तो चिराग ने सारी इम्यूनाइजेशन कर दी है, हम क्यों जाएंगे, हम तो अपने बैठ के स्वेटर बुन रहे हैं। So I think that is not the right way to address health provision in a country. Next. Now, whenever we make any intervention, I mean, all of us, and this refers to any intervention, it's not only health, sustainability of interventions can be in ecological terms, in terms of any program, because you actually want your community to move towards health, self-reliance. So what I did is I made a kind of a grid, a triangle, those villages that could be sufficient in their ability to sustain their health programs. There were 5 villages where Chirag's inputs had been very good, and the government infrastructure was also now beginning to take care. And they were quite on their way to self-sustainability in the sense that they could approach the government providers and tell them that come and give us health provision. Then there were 5 villages that were operating at middle level of sustainability, means they still needed a lot of hand holding by the NGO. And so I kept them at the middle level. And there were some 5 villages where more mobilization was required in all aspects of healthcare. And this way, if we moved upwards towards self-sufficiency, 5 more villages could be added in a process of 3 years. So this was just my representation of the interventions that needed to be happening at the community. Next. Now, this diagram is very, very important. Those of you who've seen my earlier work also, can we go back to the diagram? Yeah, this is a very, very important diagram. I've put health and well-being at the center, the woman at the center. Now, what is she surrounded by? Information, access, control over her own reproductive body, her family, her traditional knowledge systems, her food habits, her education, her agricultural practices, the myths, rituals, taboos, and religious beliefs surrounding her, the social fabric of her community, and her work roles. Now, this is a holistic representation of the health status of a woman in a community as has emerged from this research. And it's a very significant way of looking at, holistically looking at her health and well-being. Because not only is she connected to going to the doctor and over the counter taking a paracetamol or a ibuprofen for her health, these are all the different factors that are impinging on her health status and her well-being in the community. Now, based on this material knowledge, I set up a training center for rural adolescent girls. This is an amazing training center. It is still existing in Chirag. I got a grant from the Embassy of Denmark. They have an outreach development aspect called DANIDA, Danish Aid. And since my husband was working with the Danish embassy, I approached them and said that this is a very, very significant thing. We should set up a training center where rural adolescent girls I started with. But subsequently, I believe Chirag has trained over 400 boys also. And the curriculum for this was taken from various international agencies. Next slide. So what was the action plan? The future women, mothers, adolescent girls in Kumaoni. So I now started working with this age group after having studied what was articulating on the ground. Next. Now, the training module that I developed for them had many components because, you know what, it is again a holistic development. So reproductive and child health was only one aspect. These emerged from the young people themselves. They said that, Didi, we need training on legal rights. We need training on water resources because we go to get fuel, wood, and water. We want to have information on micro enterprises so that we can become social entrepreneurs. We also look after our domestic animals, so we should have a module on animal husbandry. Then we need to know about what is Panchayati Raj, women's reservation, our participation in local self-government. We need a module on first aid so that we can attend to basic first aid care at the home level, and agriculture and horticulture, because our lives are deeply linked with the land. And last but not the least, a module on forestry. Now, I'm not an expert on all the areas. So I only worked with them on one area, which is, as you know, from my ground study, I worked with them on the reproductive and child health module, which was a 5-day module, which we developed incorporating all that one had found on the ground. Next. Now, what is the process of setting up the Adolescent Training Center? Chirag had a concept of an Adolescent Training Center, which I shared with you, that Kanailal asked me to set it up even before I had done the study. And I said that, no, I cannot do that. As you know, I did a need assessment in several villages, and which focused on the reproductive child health as the first training. Then the shared the module with resource persons. Now there are, if you know, the United Nations, the UNFPA, the UNIFEM, and other UN bodies have developed, UNICEF have developed at least 150 modules on reproductive and child health. I'm not the first person to do so, but based on the findings and the analysis of the traditional healthcare practices, I tweaked these modules and did a desk review of the modules that would most suit this kind of a ground reality, and then went out to hire Sahelis. Now, who were these Sahelis? They were friends or Sahelis for the field centers. Now, the Sahelis used to go from home to home and talk to the mothers of the adolescent girls and say that, "Hum aapki beti ko 5 din ki training ke liye training center le jayenge." And what is the value of this training? First, I trained the Sahelis. Then the Sahelis themselves would go from home to home, and they had a great impact because, see, you are doing a snowballing technique. The young people in the village itself were trained as being Sahelis. So the mothers of those other young girls who were being brought into the training program were also very happy. So we had a group of about 20 young girls from each village. And then we also made some admission forms just so that, you know, they felt that they have participated and contributed to something. And then I did a capacity building, which is called a training of trainers of the Chirag health staff, so that they could in future, since me and other teams from Delhi would not be there all the time, if they were trained in doing these trainings, then they could continue to do those trainings. And this training then continued. We formed 2 groups at the various villages, and we strengthened the attendance by going to the homes of the girls and encouraging their parents to send their daughters. Then the whole 9 components of the course modules were developed in great detail. And these were the first 5-day training was held with 20 adolescent girls. It was a residential training, and I can't tell you how wonderful it was. These girls, you know, they really got transformed through this whole process. They were articulating, they were talking about using contraception, they were talking about delaying marriage, they were talking about how they would handle sexual intercourses, they were talking about how they would wear the sanitary towels, how they would keep themselves clean. And it was such a rich discourse. And added to all this, in order to, you know, give them another skill, I would also teach them sometimes tie and dye and making candles and making cards with pressed flowers. And we would do other activities also, so that the training center was enriched. And then we did a pre and post analysis, means the health information of these young girls before the 5-day training and the post after 5 days. The same questionnaire was administered, and you will not believe the increase in knowledge. Absolutely, almost 90% increase in knowledge, because they were all young girls that had gone to school, and college. Next. Now here, you know, I talked about skill building. You can see that there is a stage, and the young girls who were trained, they're doing a small play, and their mothers are watching, and the candles are being sold, and the cards are being sold, and pickles are being sold, and tie-and-dye dupattas are being sold. And we had a kind of a mela where the whole community participated. So since I could not take a photograph at that time because I didn't have a camera, I made a small sketch to show to you what it was like. It was really quite amazing. Next. Now let's quickly, my presentation is over, but I want to walk you through the concluding thoughts, because it's very important to tie up what we are saying. It's all right. I mean, I've said what I wanted to say. What does it all add up to? The entire study calls for a holistic approach to health, a judicious blend of traditional healthcare practices and modern medical systems. There is a need for integrating the voices of women who are the repositories of traditional healthcare practices for sustainability of healthcare interventions. This is a very important point, to integrate the voices of women and their wisdom into the healthcare provision system, because their wisdom, their knowledge has some meaning. And those practices that are not scientific, we need to have discussions with them, and not to denigrate them, saying that you are aap log रूढ़िवादी ho, aap log ye karte ho, and to put them down, but to adopt an inclusive process. Studies like this demonstrate the value of understanding culture as an important determinant for addressing health needs of any community. Now, this is a very important point, because culture as an important determinant. Culture is a very important social determinant. And when you want to understand any needs of any community, whether it's their forest needs, whether it's their physical needs, whether it's their household needs, whether it's their financial needs, you have to look at culture as an important determinant. Next. The study explored women's health practices from a community-centric perspective. Now, this again is an important point, because as you saw, the whole research was community-centric. Integration of the dialogue with the women with the quantitative matrix provides a richness and a context to the findings that is helpful for implementation of sustainable action plans. And it was immensely valuable, as it helped to complete the research action loop. Now, very often what happens is we stop at the research only. I did not know that I would get the opportunity to set up a Kishori Shikshan Kendra on the ground to complete the research action loop. So I was eternally grateful to Chirag. As I shared with you, I took sabbatical for 1 year to do this work from Lady Irwin College after my PhD. And this was my postdoctoral research. And then I wrote a book, because it was so valuable. The data was so valuable that I just could not stop from sharing it in a book. And that's why the second book, Traditional Health Practices of Kumaoni Women, Continuity and Change. Next, Sonali. Thank you. Thank you so much for listening. And here is my email ID. Thank you for listening.
Thank you, ma'am. That was truly amazing. I'll just close this and pin myself up. Ma'am, thank you for that wonderful approach, behind the scenes approach, which actually goes on to understanding a community better. And having lived in a rural area myself, I know it's so important to talk about all of this. And you have not only researched, but also made an effort to kind of bring it into application. And that is why this study is so important. Anthropology, doing qualitative and quantitative studies, understanding what a place needs, what are the dynamics, the subtle dynamics that can only be revealed through such a rigorous study. And I absolutely loved the way you have done your sketches. They're so, you're such a wonderful artist as well. And one thing I wanted to bring Reena in. Reena, if you could come online also. Reena and I, when we started the small clinic, that was the first thing we faced. Women would not come to us. We had to go to them. And though we did it in a very small scale, just starting a free clinic for people in the villages, but gradually they started coming in. Reena, can you come online? Is she there? Yeah. Hi, Reena. I just want to start the discussion with Reena. What was her experience in engaging with a few women she did with, and then we'll open the talk for questions for you, ma'am. Would that be okay?
Okay.
Yeah.
Yes, that will be fine.
रीना, बताना, जब हमने क्लिनिक स्टार्ट किया था, तो लेडीज को हम कैसे अप्रोच कर रहे थे? You are muted, Reena. Unmute karo.
Reena is muted.
Sorry. हाँ, मैं ये बोलना चाहूँगी कि हम लोग तो मतलब नॉर्मली मिल रहे थे, फ्रेंडली एकदम हम
Hmm.
सब लोगों से। और फिर जैसे हम मिलते गए उसके बाद में हमें लोग मिलते गए, उनकी क्या वीकनेस है और फिर हमने उनके साथ काम करना स्टार्ट किया, तो हमें पता चला कि उनको बहुत नीड थी कि उनको फिज़िकली, मेंटली सपोर्ट की ज़रूरत हो और हमने उनकी काफ़ी हेल्प की, काफ़ी लोगों को इफ़ेक्ट भी पड़ा और काफ़ी लोग ठीक हो भी रहे थे।
Yeah, and the last
मतलब
was,
काफ़ी लोगों को फ़र्क पड़ा हमारे।
और हमको सबसे ज्यादा खुशी जब हम एक्चुअली वी वर अबाउट टू मूव, an old lady came from a very high place. She walked with a stick just to get her
Hmm.
blood pressure checked, because
That's
she
nice.
had heard through, you know, the grapevine that there is an institute here who check basic healthcare, and instead of going to the town, she came to us, and for us that was a victory of sorts, that
Hmm.
we were able to do that. So ma'am, with your work, I'm amazed that so many people have been touched by your work, and you have made a tangible change, and that is really amazing. So I would like to put all of, you know, you can ask your questions now, getting a lot of comments of your work with beautiful illustrations, and very enlightening session. So if you can
Hmm.
have your hands raised, that would be wonderful. All of you who are here, and we are many. Yeah,
Hmm.
Mahima, you have a question? Mahima, you're, yeah.
Am I audible?
Yeah.
Okay, so my question would be that in terms of what is the understanding of the women in terms of latest healthcare practices? Are they okay with it, or they still stick to their traditional aspects? Uh, Sometimes, you know, that during childbirth also a lot of women, I mean to say, a lot of women used to die, and sometimes, you know, in villages and all where the local dyes are there. So when, you know, modern medicine comes in, are they adaptive to new practices as well, or they like to stick to their old traditional belief patterns?
No, the younger women, Mahima, are very open to institutional delivery. There is a shift that is happening. So you know what, I did a wide range of interviews. So I interviewed women from in the reproductive age from 18 to 45, and I found a lot of difference in what the younger women were doing, and the institutional deliveries has now gone up on the increase. You know, and younger women, see, now there are also nuclear households. Some women shared with me that दीदी हम तो अकेले रहते हैं अपने पति और बच्चों के साथ, तो अगर हम खाना नहीं बनाएंगे तो क्या होगा, हमारे पति थोड़ी मदद कर देते हैं उन दिनों में जब हमें महामारी होती है ड्रेस देने के लिए. So you know, things are changing also, but it is very difficult for a woman like, you know, I just did another study on community perspectives on education, health and livelihoods in the Talla Ramgarh area, and we found that, you know, collecting the data also was not very easy. Where the mother-in-law was present, the women were not able to articulate. So it depends on the nature of the household also. If there is an elder sister-in-law, there's a mother-in-law, and the traditional systems are still operative. Whereas if a younger woman is living on her own, and you know, then she's able to assert herself. So things are changing because, see, education is quite high in Uttarakhand. Young women are going to, some are mostly are doing double MAs, and they don't marry till the age of 22. So that maternal mortality rate has gone down drastically in Uttarakhand. You know, there has been, and the
Yes, ma'am. And
Thank
ma'am,
you.
so you
Thank
know,
you.
yeah,
hmm,
and also the separation during the menstrual cycle, that's very also interesting, because even in Himachal we see that different areas in, when you go to villages, they have different bathing areas as well, which are lower than the areas where others can bathe in the village when they're not going through their menstrual cycle. That's something I learned. I also learned that in educated families, women are kept separate in their rooms, not allowed in the kitchen. You can't
hmm,
take anything from their hands, which was quite an eye opener, because it's not only like rural women, but educated women who are living in big towns like Kullu and Manali also have to do this. And
yeah,
and if you look at the people, the Kalash people, where they also segregate people in the mountainous area. You know, they are supposed to be the descendants of Alexander the Great.
Yeah.
And but they make merry and they enjoy. And all of these things, I think stigmas are basically to hide what really, like, women need rest. That's it. They need rest. Yeah. So that's so wonderful that mountain communities all over, they have these practices, and the subtleties of these practices, the way you're unraveling, that is really very
Yeah.
informative and detailed. Rajoli is here. Rajoli, you can ask your question now.
Hello,
Hello.
Hello, Rajoli. How are you?
I'm good. How are you, ma'am?
I'm good.
She's with
Thank you.
Dr. Ian Baker right now. She is on a different mission for a month. She is doing
My
research
God.
work with Dr. Ian Baker.
Isn't that amazing? I tell
Yes,
you.
I'm so
What a
proud of
great
her.
scholar to her.
Yeah,
Very proud.
she's a gem. She's a gem. Yes, Rajoli.
Okay, ma'am, thank you for this wonderful presentation. From the academic point of view, you actually laid a beautiful footprint for all of us to actually, conduct research and how to examine and how to collect qualitative data. For me, as a young researcher, it was very informative, and I think I'm going to use your method and approach of, sketching and drawing the details and having one specific narrative, which you described in such a beautiful manner. So I learned that from you today, and I
I'm
think I'm
so
going
happy.
to.
You must illustrate, even when you're working with Ian, illustrate all your work, illustrate the processes. I'm telling you, it is so valuable that it is amazing. Later on, and then you can write notes below that. You know, or
Right,
weave all the narrative. Yeah, it'll be a great thing.
right.
I'll feel so
So I
happy
really
if you
want
did that.
Yeah, I will. I'm definitely going to incorporate it. Another thing, so while you were, narrating about the ordeals that the woman goes while she's on her periods, and so you mentioned that after, when she's kept separate in the forest, the first thing that she has to do is go into a river and take a bath. So I wanted to know why that ritual is there. If you could just
that,
elaborate.
earlier I forgot to mention that, women used to wear a 60 yards ka ghagra. This was traditional when they was segregated in the caves, na? And normally it was black in color. Now all she had was cloth to wear. And so how would she keep herself clean? Sometimes they would, she would take a mat along with her, and she would just sit on that mat and sleep. Can you imagine the fear of animals and all, and what was going on through her mind? I mean, it's just so scary. So then after her, when she would go down to the river or to the gorge or wherever, if there was a waterfall, to bathe herself and to clean herself, only after her period was finished on the last day. That's to clean yourself, because and to wash your clothes also. Because there are no sanitary towels to dispose of. So a lot of the people, that they believe that if a menstruating woman walks through a field, all the crops of the field will dry up. And their practices were, in a way, they have no scientific nature. And I used to sit on meetings where the Chirag staff would, say to them, like Naomi, the health worker, she would say, अच्छा आज मेरे periods हैं, मैं तो तुम्हारे खेत में से निकल के आई हूँ, तो कुछ भी नहीं हुआ, ऐसे तो नहीं है. So, they are willing to understand, but these kind of practices have come down over the ages, and it's very difficult to do away with them, break them. And also,
go on.
The shift has happened, like from being out in the forest to the cowshed in the house to a separate room in the house. So at least the shift has taken place.
And ma'am, another thing, in Himachal, in rural Himachal, I've noticed that they say, and scientifically what they say is that women give off some kind of very powerful, vibration, which is not conducive to the others, because they're so powerful in that element that they have to be kept away. This is what I've learned from many people, that one of the other reasons. I don't know where they're trying to, understand this whole phenomenon, or it is just something that they have learned from, their ancestors. So
yeah, there's a whole chapter in the, I have a whole chapter in the book on menstruation, because I found it so important early on. So
so
if
Yeah,
you, there's a
Sonali,
few.
yes, ma'am.
yeah. Sonali, I would just like to say that there is absolutely no scientific or clinical uh, uh, support for this statement.
Mm-hmm.
There is the only thing that helps crops dry up is weather conditions, lack of water, lack of irrigation, excessive use of pesticide. It has nothing to do with women's uh, menstrual cycle. But recently, when as a health researcher, when I went to Auroville and Anjali and I went to Auroville, when their garbage management team
Mm-hmm.
told us that disposing of menstrual waste, especially in the Himalayas, is a big challenge
Mm-hmm.
because you can't put it into a landfill, you can't burn it, you can't just leave it lying around because the menstrual fluid and the blood uh, seeps into the topsoil, and that's not very healthy. These are the health determinants,
Yeah,
but definitely nothing to do with the menstrual cycle and crops withering away. That is a myth.
Yeah, that I totally know that, ma'am. And even with I've noticed that people who are on the lower rung of the caste, they also even mensurating or not mensurating. This whole talk about हमारे मुंह में छाले हो जाएंगे अगर हमने इनको
हाँ,
देख
बिल्कुल.
लिया.
Yeah,
They talk
बिल्कुल.
like that, and
Yeah,
there's no logic to it. They'll say,
there's no
oh, this
logic.
person can't come in the kitchen. हमारे मुंह में छाले हो रहे हैं. Like that.
बिल्कुल. कि
Yeah.
आदमियों के मुंह में, औरतों के मुंह में नहीं होते.
Yeah,
आदमियों के
yeah,
मुंह में छाले हो जाएंगे.
yeah, yeah. And also it is so closely linked even to transpossession, that women can't go into transpossession because they're impure. It's only the men's thing that it connects to religion as well. They can't go to the temples during this period. So
Yeah, Shonali, Vijay Lakshmi is here. She's done a review
yes.
of this book. She's what I want to say is that she has done a review of this book in the International Journal of Health Communication at Chicago. It is this thing by Taylor and Francis.
Yeah.
I think young scholars would do very well to read that review.
Yeah, can we, ma'am, if you could send us the link to your
Vijay,
paper, we will.
Vijay, could you send them a link to your review?
If not now, even then we can put it on the WhatsApp group also, so everybody can get access to it. Yeah.
Vijay, do you have a link to your review of the VBOS?
Yeah, I do. Yeah,
okay.
I have to.
Yeah. And Vijay ma'am and Anjali ma'am, I had to tell you that by the end of April, we will have our Himalayan Conservation and Preservation Society set up here in the US. And the main reason I've done that is to get grants for projects that we have been talking on. So I have 3 main projects that I'm going to be putting up, and I'm very grateful. Vilika is on board. She's a board member. She has agreed to be on the board. Ian Baker is on the board, and a few others, American citizens mostly. So that is to make sure that we work in the Himalayas, because while in India, getting grants and all that was quite tough. And I frankly was in a space where, dealing with a lot of things, but setting it up here is going to help us push what we need to do in the Himalayas. And that is a top priority on my mind. So I want you both to know that I really want both of you to come to Dhami, stay there, do workshops. We really need to do a lot of work, and we can't do that without your support. So I really want you to come soon.
Okay.
Yeah. Nandini ji, you have your question.
Actually, this is not a question, Anjali. This is a fascinating talk. But
thank you.
Yes, but once upon a time when I gave up academic, I was running with my brother in medical disposable business. And long ago, I kind of tried doing the local sanitary napkin. It was a history. I just gave up. I have come back to my own, what my brother is doing. But here in West Bengal and some other places, I can see And you know that there are so many movies. Sanitary napkin is a movement. So government is extending lot of support, and I can see that in remote villages they are kind of organizing sanitary napkin, low cost sanitary napkin units made of different kind of materials. So in West Bengal, in Orissa, and in some other states, these are the initiatives, and the panchayat and government is spending whole lot of money on this. And also the awareness program, the whatever. But I just want to ask you whether government in the area where you work in Himachal has been thinking about it or taken any initiative, or maybe it hasn't reached the area where you had worked. So it is quite interesting to know.
Yeah, you know, this small scale units to make sanitary napkins is coming up as a new issue. As Vijay Lakshmi just said, we had gone to Auroville, and there is a small unit called EcoFem. Vijay, will you talk about EcoFem? Hello? Hello? I don't know if she's there. Anyway, EcoFem produces sanitary napkins out of different materials, which can be replicated and duplicated in small.
EcoFem is washable. Nandini, EcoFem is washable sanitary pads. You could actually wash them after using them, and you can reuse them about 6 times. They can be washed. It's made of very soft cotton material with a very thin plastic lining. And they have a marketing model. And they also distribute them free. But whether the government is taking it up or not, I don't know. Because the government still has the old system of depot holders, whereby the A&M and the health center, the PHC, has a stash of these low-cost sanitary napkins that they demonstrate and they give for free, and then you can buy this and subsidize it.
And I think they're also pushing for holders, menstrual holders also, cup holders also. They are rooting for that now a lot. So we have a question from Ritu Sharma and then Upasana.
Okay.
Hello everyone, and hi Sonali.
Hi.
Thank you, ma'am Anjali, for this talk. And
thank you, Upasana.
We really learned so much from your talk, and the difficulties that the women have to still face. So there's one line you had said that you had mentioned that the women would tell her son that तूने चूड़ी नहीं पहनी है क्या, चूड़ी पहनी है क्या, to when he wanted to be a part of his wife going to the doctor. So then didn't they feel that they were also daughter-in-laws before? And they also did not like the behavior of being segregated during their menses and other things. So, and the ordeal they had to face. So didn't they want a change? Have they ever shared that?
You know what, Upasana, very good question. Because the way the elderly women in the household had suffered, you know, like, I mean, there were 3 women I met who were in that age group, 60, 65, 55, 48 or something, and they were saying कि औरत होने का दुख इतना दुख होता है. So I said कि I thought कि तुम लोग तो इतनी शक्तिदायक हो, तुम लोग तुम हिमालय जैसे दृढ़ हो, तो अपने आप को कमजोर कैसे मान लिया तुमने कि औरत होने का क्या दुख है. So she said 60 गज का घाघरा पहनना, जब महावारी होती है तो जंगल में जाके रहना, और नथ पहनना, 10 किलो की हसली पहनना, पाँव में बेड़ियां डाल के ये एंकलेट्स डालना. तो औरत होने का दुख ही दुख है. और सबसे ज्यादा दुख है बच्चे. अगर मर्द को बच्चा पैदा करना होता तो वो तो दौड़ ही jata. So, I mean, their narrative was a little different. Now, they were coming from a gender discourse where they had been marginalized and treated very harshly by their mother-in-laws. So they don't understand this new thing about, participation and male involvement and all that. So there is a kind of a ridicule happening. कि क्या तूने चूड़ियां पहनी हुई हैं जो तू उसके साथ उसके डॉक्टर के पास जाएगा, उसका ब्लड प्रेशर लेना, उसका यूरिन की जांच करानी. So if the man is strong enough and he kind of jokes it with his mother and says that माँ आजकल दिन बदल गए हैं, मेरे जाने से फर्क पड़ेगा, डॉक्टर को भी असर होगा कि कोई इसके घर से परिवार से आया है, something like that, the whole thing gets in a way. But she can't change her own life and her history. So perpetuating, and this is a deeper question, Upasana, for all women in this country. Why do mothers, women who have suffered, perpetuate suffering on their younger daughter-in-laws? When actually they should stop perpetuating suffering when they have suffered. And this is a deeper question.
Sometimes I think they feel that if we have faced it, let my daughter-in-law, others also.
I think it's at the psychological level, like a rite of passage, rite of passage. And we did it, so why can't you do it? It's tradition.
Absolutely.
Yeah.
Absolutely.
And even in educated families, we face it in a very subtle form.
Right.
We still do.
Yeah.
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 It's like that for, it's just the degree varies. The degree becomes stronger in a rural setup rather than a city setup, but we all face it at some point in our life.
And also, small cities, this thing. I mean, what Upasana is saying is a deeper question of gender.
Ritu is saying, Upasana has yet to say.
What Ritu is saying is such a deep question of gender, honestly.
Yes.
Thank you so much, ma'am. And I think it was a wonderful talk. I mean, we just got an insight how some people are still leading their life. Thank you so much.
Thank you, ma'am.
And in your own work, each one of you can incorporate these ideas and make it rich.
Yes. And Upasana has a question now. Upasana, over to you. You're muted.
Hello, ma'am. That was such a wonderful talk, and I thoroughly enjoyed it. Ma'am, I just wanted to ask you, in fact, it was a very curious question that during your group discussions or meetings with men and women of the village, how did the men receive these information, or how did they open up to you, discuss with you about their experiences, or their knowledge about health and health practices in the region?
No, they didn't. Not at all. It's very, especially my focus was on women's reproductive health phases. So it was very difficult to ask men. In these meetings, I'll tell you what happened. Service providers from the government would come and they would talk about their whole health infrastructure and what is available, that if you have an institutional delivery, you will get 15,000 rupees, plus you will get this access to this and all that. They would just talk about the schemes. And the men were present there. And when the women were present also, I would urge them to articulate their concerns of that. Sometimes, when they go to a doctor, they are not attended to properly in the primary health care. Most of the time, the primary health center is closed. There is no doctor available. Why all this is happening? Absence and health-seeking behavior has to increase. So the women would not speak up about their concerns at these meetings. It was, it was mainly like the government health service providers and the men listening to them, especially in terms of what schemes are available. But nothing about, her own personal narrative that she's suffering. She has to go and collect fuel wood and fodder, and that impinges on her health and her pelvis and all that. See, women don't really give themselves so much importance. मैं तो ठीक हो जाऊंगी, मुझे तो भगवान देख रहा है, that kind of a thing. So they would not voice their concerns in front of them. But I've noticed that the community health workers and the DAIs who were working with Chirag, if the meeting was held just with the Chirag staff or the Chirag doctor, me, and the health extension workers in a very kind of an inclusive environment, then the community health workers would talk about their problems in reaching women at the community level. Then it provided like a safe space. So sometimes, creating spaces for articulation becomes very important. So this is another very important point that your question is bringing up, creating safe spaces for articulation of rural communities about their concerns. If we could focus on that.
Yeah. And also
Yeah,
with
and
ma'am, sorry, go ahead, Upasana.
Yes, ma'am.
Go ahead.
Ma'am,
Yeah.
what about men? Like, did they open up in these kind of discussions? The men?
Upasana, male
Huh.
participation is still very difficult to engender in any community, especially in hill communities, where it's a lot of hard work and the women work much harder than men. They collect water, fuel wood, even today. Even though they don't wear the ghagra, they don't wear the hasli, they don't wear the nat. They may wear jeans or they may wear salwar kameez, but their roles and responsibilities in the home remain as maybe not as heavy because they don't carry head loads, they've all got LPG, but working in this women's collective, we find that women get very little time to themselves. Even if they have a hand skill that they've learned and which brings money into the household, but getting that space and that time to work on that, even though she's an income generation person, is difficult. So women still don't have what we call agency. They don't have that. So until they have that, and women everywhere have less agency. But women in the hill communities where life is so hard, the terrain is so harsh, it's very, very difficult for them. So what Anjali found in her first book, her second book, and now what the work we are doing, the scale may have changed. There may be some labor-saving devices. But if we want to launch a communication campaign using the cell phone is only with her when she comes to the center, not in the evening when the children are home and when the husband is home. If you use that as an indicator of agency, then she doesn't have agency. If you use access to healthcare as an agency, she doesn't have agency. Yeah.
Ma'am, there's a wonderful film. It's made by a friend of mine. It's called Parched. It's on Netflix. I urge everybody to see that film. And you just talked about the cell phone and how the cell phone became a vehicle of change and a vehicle of that tussle and conflict. It's a beautiful film set in Gujarat, rural Gujarat, Parched by Leena Yadav.
Okay.
So Leena is a very dear friend. I invited her for doing talks in my classes as well. And she really talks about, things like this, very subtle things, and how the community and women themselves, how do they navigate their lives through all of modernism and the past and these traditions. So that's the name. And of course, ma'am, your insight is so important, like what all is happening. A simple thing like picking up a pad, from the garbage. Healing Himalayas, for example, they're doing commendable work in picking up garbage. But really, what do they do about this kind of garbage? And how do they inculcate those policies? Like, we need like so much of discussion on this, because all of these are so connected. And you both have done amazing work. This is like truly, it can change how a community looks into these little things, which are so important for their own identity and their self-worth as well. So, yeah, Aditya has a question. Finally, we have a male who has a question.
Thank you so much.
Thanks a lot. So I had a question whether the agency does it. Am I audible?
Yes, you're audible, Aditya. If we could see you, that would be lovely. And if you could give a brief introduction also.
Okay. Just a second. I'll have to open my camera. I was on the terrace. I'll go down.
Okay.
Sorry.
Yeah. No worries. No worries. Okay.
Yeah.
Yes,
thanks a lot. So,
yeah.
So, hi, my name is Aditya. I'm working as a data scientist. I work in the domain of basically social sciences. So applying data science methodologies into social science is something that I do. So yeah, that's a brief introduction about myself. My question is that, whether SHGs, self-help groups and cooperatives, do they have any, or providing women with the knowledge of entrepreneurship and all, does that improve the agency of women in making financial decisions, as well as agency in making household decisions as well, particularly with respect to the hills? I mean, does that has any impact, or are there any narratives out of it? Just would love to know that, if there is something related to that.
Aditya, I'm glad you asked the question. This is Vijayalakshmi, and Anjali can answer as well. We're working on a livelihoods initiative in Kumaoni, in 10 villages, 5 villages in a 5-kilometer radius. And we've done a landscape study, which we can share. I have an e-version also. And it clearly shows that the empowerment comes much later. It's first the income that makes a difference. Then comes a decision-making power, that when she's able to send her child to school, then she says that, okay, this is what is good for my child. She may or may not be heard, but at least she's saying it. So then follows articulation. Empowerment is a very relative term. She may be empowered enough to say, I need 3 hours off to go to the center and to work on my kantha, on my crochet work or my sweater, because remember, that's what's giving you the money. But that's it. Her decision-making or critical thinking powers will not spill over into any other activity. She cannot decide that she wants to send her daughter to college and not get her married. No way. Those are still dominated by traditions and custom. So it's all very relative. And the only thing that I see changing from Anjali's work to our work is the fact that institutional delivery and safer pregnancies, thanks to the initiatives that have been provided by the government vis-a-vis money transfers, conditional cash transfers, is what has worked. So that is my take, but I'll let Anjali comment on this.
Ma'am, you're muted.
अंजलि वो कर लो आप, अनम्यूट कर लो अपना, अनम्यूट. Can you unmute her, Sonali?
Yeah, I'm trying. I'm constantly clicking on ask to unmute. It's now.
Hello.
Yeah, she's done.
There she is.
Yeah.
Sorry,
Yeah.
Anjali, can you repeat that? We didn't hear it.
No, I'm sorry. What I said was, you very clearly articulated the different levels within a household where decision making happens, and that empowerment is absolutely relative. Now, a woman who is coming to the center to work on her skill and earn money as a social entrepreneur does not necessarily go home and translate that independence into her decision making process. Whereas, so all this is going to take time. Now, I have found that ambulance of 108, or in our latest book, Community Health Perspectives on Education, Health and Livelihoods, there is a little bit of shift, very minute shift to institutional delivery and contraception, and using health contraception in order to do the spacing for the child. So there is some changes are happening, but whether it leads immediately to empowerment, I think is a very relative question, because how empowered are urban women as well will also be relative. So I think Aditya's question is multi-layered. It's very difficult to answer it. Yet I do want to say, as Vijay has pointed out, Vijay Lakshmi has pointed out, that from my work in 2004 and today, there has been a shift, but the shift is more in availability of household level support systems which do not impinge her on going to the forest maybe twice a day, and she has some kind of supplements to her resources, but it has not led to total empowerment, as you may say. So we all have to keep looking for that.
Yeah.
And we have written a book. I would also like to share, Shonali, that we have spearheaded a book called Transforming Life, Stories of Change of these women who come to the center, to the Khushali Women's Collective, on how they feel, what is the most significant change they have perceived in their own lives. And that book is just going to come out. It has gone to the press as we talk today.
Oh.
And it has been written by Deepti Mehrotra. She's a gender specialist. The narratives, and Vijay Lakshmi, me and Anju Khanna have put it all together in order to share the women's narratives on how their lives have been impacted. So I think people will also benefit from that, though it's not focusing on health, but it's on their whole lives.
Ma'am, that's wonderful. Even at Dhami, we have now Reena is a qualified yoga instructor as well, and she has training as a nurse. And Lakpa Dolma, Dr. Lakpa Dolma, she's coming in. She'll be doing workshops on Tibetan medicine, and she wants to reach out to rural women. She says it's very important. And I feel the both of you would be so instrumental in doing this. I think our Wisdom Traditions project will be lovely to take off and do workshops, regular workshops in Dhami. We should definitely do that.
Yeah, Vijay is a great resource, and I together, both of us have worked so much on health. She's a health communication specialist. So somebody called Vibha said that she has uploaded the link of the talk, the book. So that will be wonderful.
And Vibhaji also mentioned, I'll just mention this last thing, that a lot of women face like problems carrying heavy bags, heavy loads, and they have a problem in the uterus. And just yesterday, one of our staff members who works with HICHS, he's in Nepal because his mother has this problem. He can't leave her alone because she can't carry load, and she has a problem in the uterus, and there's nobody to help. And it affects not only the mother, it affects everybody in the family. He cannot come back because how can he leave his mother like this? And there's nobody to take care of her. Like, how do we deal with, all these people who get affected by the wonderful mother who's going through this?
PID, pelvic inflammatory disease, retrovert uteruses, very, very, very rampant. Gonorrhea, leukorrhea, white discharge, all. And these are, I mean, we feel that we have moved in our healthcare provision. There is a blanket way in which white discharge is taken. Then there's no testing of what type of bacteria, what type of antibiotic will deal with what type of thing. They just prescribe them a generic kind of a tablet. So there is so much that needs to be done in our country. So much work, honestly, on the ground.
Yeah. And you're getting a few... You're getting a few messages, and Vibhaji has written, fantastic talk. I wondered if there's a follow-up study. Also, what is the position of DIEs nowadays? Government also had a midwife training program. So how does it work alongside traditional role of DIE? Yeah. So there's so much of interest that you have kind of, pulled in.
So we can continue our dialogue because I'm just exhausted.
Yes, ma'am. Please take rest now. I know you're not well. But this is wonderful.
I'll take that question about DIEs.
Yeah.
The DIE program has been discontinued, and now it's the auxiliary nurse midwife who's supposed to do this, but institutional deliveries are being encouraged across the board. PHCs now have at least 3 or 4 beds, and they do have institutional deliveries are going up. So DIEs are more or less discontinued. There are some studies that say that it's a good thing. Some studies say that they're available and they should not be discontinued. But they did have some very unhygienic practices like using cow dung and cow urine randomly. So, it's maybe it's just as well. So it remains a gray area. But I would say the DIEs, if there's nobody and you're snowbound or you're facing a thunderstorm and then there is a DIE who can deliver, fine. But if you have an option, then go to a hospital which is ASAP, because sepsis is a big problem still. leads to a lot of maternal mortality. So in that scenario, maybe a dye, is not a very good option. So it's, as I said, these are very, like Anjali said, very tricky issues. And, this is where narrative research comes in, is very, very important to support quantitative research, to hear women's voices, about the kind of deliveries they had, the kind of experiences they've had. But yeah, the DAI program has been discontinued as a government initiative, though they still may be there as informal initiatives.
So, ma'am, thank you so much for your input. And it's so wonderful to see you both here. Please keep coming. Next week, we have Dr. Bala Ganpati. He's the department head of Philosophy, University of Delhi. He'll be talking about the Mahabharata in Uttarakhand. So he'll be talking about that chapter.
Awesome.
So, and we
Wonderful.
have Ed Douglas after that. He will be talking about Himalayas, a human story on the 22nd of April. So we have a good lineup of talks. We want, ma'am, you also to come to give a talk on your work, ma'am, Vijay Lakshmi.
I talk enough, Sonali. I need to talk more. I talk enough.
No, but we need to hear you. Your
no,
talk. Yeah,
I'm not a good speaker at all. I'm not like Anjali. Let Anjali speak.
Yeah, but
but Vijay, your interventions are very, very special and very precious. So I feel like, if I say something,
we'll do something.
We'll do something together. Huh?
Yeah, and in Dhami, Molly ma'am is also
in
here.
Dhami.
Yeah, in Dhami.
I wanted to wish Anju a very, very happy birthday.
Oh, happy birthday, ma'am.
Thank you.
Thank you.
Thank you.
Hi, Vijay. Hi, Vibha. Vibha, I wish we could see you. If you've not left.
Where is Vibha?
Wonderful talk. A lot of questions, but I think, I'll keep it for when we meet.
Yes.
Especially, I am a little puzzled in terms of, the usefulness of dyes. The point is that the more their space gets curtailed and reduced, the more their expertise also goes down. And so how does one balance the two? Because I know of many cases where, the institutional or the modern facilities had recommended cesareans, and this will not happen. And traditional dyes, without any issue could deliver, So I know a few case studies, and they were expert enough to, deliver twins without any other medical outside modern facilities, and where it was refused by the modern medicine system. So,
maybe,
these are complicated issues.
Very complicated.
It's very complex and complicated, but then nonetheless, what you say is so valid that to make a counter argument is foolish, The wisdom doesn't say so. But, when we're talking about culture, what is really then is that what was that culture of hygiene? Was it that these societies were always devoid of cultures of hygiene and health? And if we say so, then aren't we falling into the same evolutionary model of, the culture as a determinant? So these are some of the issues that crossed my mind when we were talking, but I think it is when we meet and we sit down.
Let's sit down only because these are very, and now that there is a platform in Dhami, which is also similar as your place, and if we could all let Sonali get better, and
absolutely,
she's
I hope you're feeling fine, Sonali.
First round was tough. I'm gearing up for the second round, which is on the 18th. So
we'll be all sending you.
Yeah, I have 19 more to go.
I know, don't worry, they'll all be over.
But even if I'm not there, I really like the space is there, Reena, all the support staff is there.
What do you mean even if I'm not there?
If I'm not there, as in till December, I'm planning to come end of December, but during this period, if you want to do a 3-day workshop or 1-week workshop, we'll facilitate it. The whole it's all set up. We have our chef, we have Reena who's doing administration, Krishna is there for logistics, Mahima is there, her whole family is there to support whatever we do. So I don't have to be there, I can be online.
Dhami.
Yeah, in
Dhami is before Simla?
It's on the Kullu road, but it's 40 minutes from Shimla, very close by. And it's in the forest. So very, very cut out. It's the Himachal of 25, 30 years ago. It's so beautiful.
I believe it's very beautiful. Yeah.
Yes, yes. And Krishna just messaged, good talking, Madam Ji. So he's very, he's very involved.
Vibha is saying hi, our video is not working. So hi, Vibha. Yeah, good
hi,
to...
Vibha. Vibha, where are you? Really, it's so lovely to have Vibha and Molly on this talk, I tell you.
Yeah.
Amazing.
Yeah, I want you all to keep coming because without you, the energy is low. So, Anjali ma'am and Vijay Lakshmi ma'am, you have to come each. This will be like a gift to me to keep moving on in the direction that I am.
Yeah, of course.
And to all
definitely.
of us, actually, you have to be here every week.
Okay.
Yeah. So, all
thank
of you,
thank you.
Let's wish ma'am a very, very happy birthday. Happy birthday to you. Happy birthday to you. Happy birthday, dear Anjali ma'am. Happy birthday to you.
My God.
Yeah.
Thank you. Thank you.
Lots
Thank
of
you,
love.
Aditya. Yeah.
Lots of love. And we'll meet next weekend with Dr. Bala Ganapati's talk on the Himalayas, on the Pandavas in the Himalayas, the chapter that deals with Pandavas going to the Himalayas. Yeah.
Molly has done a lot of work on this.
Yeah.
She's edited. Molly has edited a whole book on Mahabharata.
Yeah.
She has done so much work, I tell you. She can contribute.
I think we need to make a whole list of the books that you've all done so that we can circulate that and put it in our library as well.
Yeah.
Yeah, we should do that.
We'll keep.
Okay. And have a great weekend. Good night. Thank you, ma'am. That was an amazing talk and very wonderful discussions. See you all next week. Bye.
Thank you. Thank you. Bye-bye. Bye.